Okay. Bismillahirrahmanirrahim. Thank you everyone for joining this webinar today. I'm so delighted we've got Dr. Caroline with us today, and we'll be going through hopefully a study that came out last year, which you may have seen. We'll be going a bit more depth into it, inshallah. But as custom, before we start, I'd like to go through some verses of the Quran, and the chapter that I've chosen is Surah Al-Marij. So this is chapter 70 of the Quran. I'm going to start with Bismillah ar-Rahman ar-Rahim, Illa al-Musallin. So basically the surah is talking about the prayerful, Al-Lazina hum ala salatihim da'imun, people who are constant in their prayer, Wal-Lazina fi amwalihim haqqin ma'lum, and those who in their wealth is a known share. And it's interesting to what Allah subhanahu wa ta'ala then talks about where that wealth needs to go. He says, Lesa'il, the person who asks, wal mahrum, the people who are deprived. And I always feel that when I look at the word deprived, and we've touched upon this before with Sheikh Jafar Ladak, that it's people who are deprived of help, or people where help has become blocked. This is very similar to the situation where we find where people are trying to get legitimate help, but they're being blocked, they're being deprived of this service. The verse goes on, and it is of those who believe in the day of recompense, those who are fearing of the punishment, and of course no one can feel secure from the Lord's punishment. Interestingly, then it goes and says, وَالَّذِينَ هُمْ لِفُرُوجِهِمْ حَافِظُونَ, and then it goes directly into sexual modesty. إِلَّا عَلَى الْأَزْوَاجِهِمْ, except from their spouses, أَوْ مَا مَلَكَتْ أَيْمَانُهُم, or who their right hands, or well, actually, أَوْ مَا مَلَكَتْ أَيْمَانُهُم, or who they rightfully possess. فَإِنَّهُمْ غَيْرَ مَلُومِينَ, they are not blameworthy for that. فَمَنْ ابْتَغَى وَرَاءَ ذَلِكَ, whoever seeks beyond that, أُولَٰئِكَ هُمُ الْعَادُونَ. And Adun is interesting because if you look in the story of Prophet Lot, the word Adun is used as well, and that these people are transgressing. And then the verse goes on describing these believers, and it's really interesting what Allah subhanahu wa ta'ala is saying. He's saying, and those people who are faithful to their trusts, their covenant, they're people who stand by what they're saying, they're standing by their testimonies. And then it goes back to how we started. It goes back to وَالَّذِينَ هُمْ صَلَاتِهِمْ يُحَافِظُونَ, people who are consistent with their prayer. أُولَٰئِكَ هُمْ فِي جَنَّاتٍ مَكْرُومِينَ. أُولَٰئِكَ هُمْ فِي جَنَّةٍ مَكْرُومُونَ, and they are of the honored gardens of paradise. So I really connected with these verses when I was going through it in times of this, where we may be blocked from certain things, but Allah subhanahu wa ta'ala reminds us to be faithful to the trust, to the covenant, to stand by the truth, stand by the testimony, and persevere in prayer. Just to introduce Strong Support and what we do for people who may not be aware, we have 30-minute consultation, which about 200 people since we started have utilized that service. We also have one-to-one coaching, which again, a lot of clients have taken that. And alhamdulillah, we have, by the grace of God, volunteers who have created these circles. So there's a circle on Thursdays for men, and the other circles are on Sundays, one in the morning for women, and then one in the afternoon for the Arabic circle. And the one that was actually created by the community was the parent circle, because the parents of people struggling with children who have gender identity or sexual identity issues, they were finding there weren't any issues. Now, there is still more talk and need of more circles for more different populations, and inshallah, we will talk about that and come soon. Last month was quite a busy month for us. We had a lot of media involvement, which is great. There was a lot of hesitance at start to discuss this topic, also to discuss it in the media, and we had quite good feedback that we are addressing these issues in the Muslim community, and we are, we're not faceless. This community isn't faceless, and that we do have a voice. Also, we were quite lucky to have engaged with the Parliament. So the Parliament is in the UK, has POST, which does research on science and technology. And they did this research briefing on conversion therapy. And they briefed me, and I had spoken to about the great work that Dr. Carolyn did with Professor Phil Sutton, and you can see in their in that study they have quoted, as well as other studies by other prominent figures as Christopher Rosick and Professor Sullins. And you can see that through this, the quote that's there, which you can almost see, is that there is a lack of representation of non-Christian religions, and they see that in their governmental survey. And the government survey was so vague, it just said, have you been offered conversion therapy? And it didn't really define what that actually meant. And the highest population which said yes was Muslim. So they are identifying that it is probably something that talking about it in the community, as we said, in the previous slides, when we're engaging with the media, is difficult, and they are recognizing that it's probably something which they haven't considered in how the law would impact minorities, and I was really happy that they did engage with us for this. So from this, what we see, I think that's some slides gone a bit right there. But the consultation has been extended now after after threat from an organization to February. So that means we have another chance. And I guess the good news is that we are seeing change. And this is an excerpt from the Women Inequalities Committee from the government, which is saying how are under 18s affected. Because basically the ban introduces this type of consent that, people over 18 or above can consent to therapy, but at the same time it says it's harmful. So they're asking, well, if it was really harmful, why would anybody in their right mind do it, right? Because it doesn't make sense. And if under 18s are questioning their sexual gender identity, we shouldn't be forcing them down one path. Instead, we should be allowing exploratory efforts in, in a very tender age of when we shouldn't be affirming one thing or the other at that age, when they're trying to discover themselves of who they really are. So I think my slides have gone a bit array. Let me just see. So actually what's happened is they've taken back at the term therapy, and they've moved it, and they said, we're not going to call it conversion therapy in the legislation, we're going to call it conversion practices. And that's really good, because that detracts the bundling of therapy with, coercive practices, which is completely different. More so because of a lot of activism. This is from the government website, and as you can read, it says key facts: casual conversations and supportive conversations which do not pressure someone down one path or the other will not be in the scope of the proposed legislation. Our legislation will not affect parents' ability to raise their children with their values of their faith. Simply expressing the teachings of religion or private prayer will not constitute conversion therapy in our proposals, and we will continue to work with faith groups on the proposals. Clinical practitioners working in line with their professional obligations and within existing regulatory frameworks will not be affected by this legislation. So, this is really good news. This is as a result of engagement that this has been possible. And I think if we had not engaged, and everybody who's watching this had not engaged with the consultation, which hasn't still ended, that this would be possible, and that, we highlight that, okay, we know practices which are coercive are harmful, which are targeted at an individual, which have a predetermined outcome of what the therapy should be, but not exploratory. And that's hopefully, we can, in today's webinar, we can go through that. Now you can find the study in the Journal of Human Sexuality. You can go to the website, as you can see here, journalofhumansexuality.com. You can see volume 12 is the latest, which is out. It has plenty volumes, and I just want to appreciate, because if it wasn't for the research that is available here, we wouldn't have something to stand on, for example, when it comes to these laws and when it comes to these legislations, because the other side is very much prepared. They're very much in that narrative, and I can't emphasize the importance of these studies and the difficulty that I'm sure Dr. Caroline will tell us in getting these to the mainstream, getting them heard, getting them peer reviewed, and not, and all the difficulty that we just don't know that exists just even before getting it to that level, let alone the sensitivity of the topics when you're examining people who are taking this, which is quite a private, like even in the UK, you don't often have studies for something of that nature. And so it's really bravery of the people who have been involved in this study, who have allowed these results to be shown. We put a link out so you can read the study. Obviously, we're not going to go through that here, but please do read it. It is it mentions safety and we'll go through that, what that actually means. And you can see from the study here that the sample, I think it was about maybe over 100 or 101 that started, but it ended up with 75 people who had finished the 2-year mark, I think it was. And you can see this is a predominantly young audience. You can see most of the people between the ages of 18 to 35. You can see almost all of them highly religious, of a highly religious capacity. As you can see that with religiosity in attending church, or obviously attending their place of worship multiple times in a week. And this isn't a bias, this is just the sample. We're just being very honest that people who are doing this work are highly motivated by their faith in doing that. We can see the desire is for fluidity, and that's really key. The desire, like even at Strong Support, we say the aim isn't heterosexuality. The aim is God centricity, and God centricity may include hope for fluidity, hope for a life that God is pleased with. And right at the bottom, you see motivation for safety. That's really interesting. What are some of the drivers that people have when they're undertaking this therapy? And you're seeing traditional marriage, having a family, basically, religious reasons, being congruent with their faith, and then social reasons. And again, you would think, oh, there's a societal pressure, or I'm not sure what's meant by social, but there may be social reasons. There might be like outside reasons. And parent suggestion, yes, there would be parent suggestion, but you're seeing that a majority of the people here are showing internal desire, and they're not driven by external factors. And that's what, kind of a lot of, I always get this. So you're from a Muslim family, right? So your parents must have wanted you to do this, or oh, you couldn't get married, so that's why you're doing this. And they don't realize that these clients are having an innate desire, an innate will for self-determination of where they want to be going, and that needs to be respected, just like it's respected for any other demographic. So recently, this, people always ask, okay, what are they using? And we're saying, okay, it's reintegrative therapy. It's at the Breakthrough Clinic. This is where the client is. And as Dr. Carolyn will mention, that she's in no way affiliated with it. So it's completely an independent study of that practice and what's going on. Now, we know recently they were in the news for, and I was like, how is it that YouTube is taking, so if you don't know, YouTube took down their videos recently for hate speech. And that really baffled me, because it was like, okay, if you look at the videos, they're testimonials, or they're showing their method. They may be showing EMDR, they may be showing other methods, which trauma-based methods that they're using for their therapeutic approach. There's nothing hateful about what they're doing. And hopefully we look forward to having Michael next session, who works at the Breakthrough Clinic. But just, I wanted to highlight that because it was just baffling to me at how difficult times have become on these platforms, where they would just take down material But the good thing is those videos are back up. So you can go, well, you can go to the website, Reintegrative Therapy, and you can go on videos and you can see for yourself and determine if you think those videos constituted hate speech or if they didn't. So finally, after all that, I'm so happy that we have Dr. Caroline. I was very lucky to have met her last year at the IFTCC conference in Hungary. I'd been waiting for the study for a while because, and probably she can share with us why it probably took quite a while to do all the calculation, the different methods that she had to, I think linear mixed model, I can't remember what the statistical term is. She's currently the assistant dean and the head of School of Arts, Science and Humanities at Arizona Christian University in Phoenix. She's a licensed marriage and family therapist and approved supervisor, having served as a mental health clinician for over 35 years. She is specialized in helping people explore safety or sexual attraction fluidity and to challenge eating disorders using narrative therapy. Narrative therapy is brilliant because, you know, we have it here in the UK. It's really underrepresented, and it's really good that we're allowed to use different therapeutic techniques because, you know, different things work for different people. As her primary model, she conducts narrative therapy workshops internationally, and she's available for clinical group training. And we're discussing the publication, which has gone out and has received a lot of attention. So without further ado, I will hand over to Dr. Caroline.
Thank you, Ali. Thank you so much. So I'm going to share my screen here. There we go. It's so great to have this opportunity to share. You know, like Ali was saying, this was a long time coming. I kept talking to people about it. I felt like you know, it was like a baby that was gestating way too long. And part of it, honestly, it was kind of funny. So, and in friendly audiences like this, I always want to acknowledge some people, in particular, Dr. Sutton, Phil Sutton, who was the right guy at the right time to come in and help me finish off the document, the manuscript. And, but Dr. Joseph Nicolosi, Senior and Junior both, you know, they're the ones who facilitated this by allowing me to do the study at their clinics. And really the instigator was Joe Senior. I'm just going to call him Joe. He was really, actually Dr. Sutton and I were planning to do a different study, and kind of a broader, you know, looking mostly at just the well-being issue and not so much the sexual attraction fluidity, because we were concerned about what was being said in, you know, around the world. And this was like a long time ago. And Joe came to me and said, hey, how about you do a study at my clinic with the well-being and the attraction. We weren't calling it sexual attraction fluidity back then, but that's what he said. And so I said, okay, we'll do this. And the plan was to gather data for 2 years. But he kept talking me into getting more data. He was a very persuasive man, he was. And I mean, literally, he kept talking me into it. And I'm like, wait, this is insane. I can't keep doing this the rest of my life. So we gathered data for 5 years. So that's one reason. I blame him. No, and then, yes, and then getting it all the information compiled, the data compiled, figuring out exactly, reconsulting with our stats people, because we had consulted with them back in the beginning as we were designing the study. And then we came back to them and said, okay, is this still how we need to do the statistical analysis? Give us some direction on this. And then doing all of that and going from there. Yeah, it was a lot. So there, it was a manuscript ready to be published. And then we start the fun of submitting it to different journals and trying to get something to happen with that. And that was, we knew it wasn't going to be easy, because the results of this study go against the entire narrative that is so popular. And I, I'm not going to go into why I think that's a whole different discussion, which would be a super fun discussion to be part of, is what are the motivations? And I'll probably bring it up a little bit as we go. But anyway, yeah, it took quite a few tries to get it published. I was trying to get it in an APA journal. That's how I started off. And just because it would get more widely read. But then, I'm like, I just got to get this thing out there, because everybody's been waiting for it, and I needed to give birth. And and I'm really happy that we ended up putting it in the Journal of Human Sexuality and give it some publicity and all of that. And I think the Breakthrough Clinic, Joseph Jr. was perfectly happy with that too. So that was important to me, that he was okay with where we had it published, just because he gave me the opportunity to recruit with his folks. So let me just move on. And, a lot of people have asked me in the past, it's like, why would you want to do this? I mean, it's not a career booster at all. If anything, it's a negative thing to be doing this kind of research. So I like to talk about some of these issues, and these are issues that I think we just discussed. We were just exposed to that, but professional associations and regulatory bodies have for a long time claimed that the research is insufficient in this area, that we don't have enough good research to demonstrate the benefits and the effectiveness of safety. And okay, but then they use the same research to establish their guidelines. The research that they say is insufficient, they use that to establish their guidelines. And so that's a problem. This is retrospective research. Some of it has, and what that means, it's research that asks people to look back, to ask them about their opinions from the past. And that's valuable research, but it's not really the kind of research we need for creating guidelines. So, essentially we have these current practice standards built on what they admit is substandard research. So it's really interesting. And we actually agree. We agree that there is limited empirical, quantitative, prospective research on the effectiveness and the benefit of safety. Most of us have lots of years, and by us, the people who are interested in talking about this, and researchers and clinicians, have a lot of experience seeing the benefit and the effectiveness of it. But and there's some research, there's some qualitative research, not empirical research, and there's some retrospective research that gives us a good idea. But it's not the kind of research that we should be building standards of care upon, and especially standards of care that limit autonomy and self-determination of our clients. Yeah, and I'll probably mention this later, but one of the studies that has guided the APA that is an example of this substandard research is the Shidlow and Schroeder study that came out, and I don't even remember, it's been around for a long time. And it is inherently biased. They recruited participants by putting up posters that said, "Help us document the harm," and then they used that research to demonstrate harm. So obviously it's not good research. I always say my freshman undergraduate research studies student would understand that that's not good. It would be thrown out. If I had recruited the same way, it would have not even been considered anywhere. So that's a big deal. But this legislative limitations of client autonomy really truly was kind of at the core of what got us motivated, where our passion comes from for doing this. I think it is the biggest problem. Most of your, well, I'm sure you're all aware of this. We were just talking about it. I really believe that this is ultimately bullying. It's bullying people who are, I believe, are the most vulnerable of sexual minorities. They're rejected by everybody, and it's because they refuse to interject this narrative, this LGBTQ narrative, that people experiencing same-sex attractions are so they're so unique and so different that they can't influence, they can't self-determine, they can't have autonomy. And so we need to protect them from themselves, essentially. And so we do that by limiting their self-determination. And if they practice self-determination, it's going to be harmful to them. It's insanity to me. And the narrative has become so twisted that people can't even hear how crazy it is. So we were really motivated by that, that these regulations were limiting real live people from just living the lives that they want to live, regardless of the motivations. It's very strange that we're offended, gave the parents' concerns as an example for motivations. And I'll get to that in a minute when we look again at the participants. But if parents were concerned that you had anxiety and they recommended that you go to therapy, would people go, "Oh my gosh, you're being pushed into going to therapy for anxiety"? My son was experiencing anxiety, and I'm like, "Yeah, why don't you go talk to a therapist about it?" And no one thought that was horrible, right? Because, it's crazy. So this is kind of my new thing now that I'm kind of out of doing the research, and I'm kind of feel like I can be back into this more of a, I don't know, an activist kind of role. This is the thing. I'm back into this place where I'm like, really, legislators are causing the harm. It's not safety causing harm. It's these legislators that are actually harming people. And this was not in the literature review of the paper. We didn't include what I'm going to be presenting here because we actually had to cut it out after the first review. We got feedback, and I agreed with it. Your lit review is too long, but I had this whole thing in there, and so we're like, okay, let's cut this part out. And so now I get to talk about that. And I think this is really an important background for people to understand that what we found in the study makes complete sense. It's completely supported with the background. So there's this group of people who have been doing research on self-determination as in application to therapy. There's a lot of self-determination research out there in education, in business, and all kinds of areas where it's applied. But this is a group of people who have been looking at it in application to therapy and what we understand about self-determination in therapy. And clients who are supported in pursuing these self-determined, value congruent therapeutic goals are more likely to be experiencing all these positive effects, more positive therapy experience, increased well-being. Actually, the change is more long-lasting, and it actually helps them to continue to do the work. even if they are frustrated in that process. When therapeutic goals are related to people's core identity and their values, it's even more important for autonomy to be allowed, because it's more likely to be causing harm. It's especially harmful if it's a core value, if it's part of someone's life guidance that they're talking about. It's, you know, just in this last week, I've heard 3 or 4 stories about people who have been limited by therapists to pursue safety, or even other issues actually, that are related to their core values. And it's remarkable how harmful and then the legislation isn't even allowing it now. So the privileging the client's agenda and protecting their freedom is essential for avoiding harm. So we will have harm if we're doing that. So again, legislators are causing harm. Yeah, and more stuff that we know about this, about autonomy and therapy, kind of taking it apart was, what does that mean? What does that look like? Understanding the client's core values, centering their agenda. And this is a very narrative therapy approach. This is kind of how I ended up really getting into this. Is I was a narrative therapist before I started working with people with, you know, unwanted same-sex attractions. And so it's kind of interesting that I'm like, wait a minute, how can you not center their agenda and be a good therapist? It escapes me. Communicating empathy. And here's one of the things that it's so important: offering as many choices as possible within the context of therapy. So that goes for safety therapists. You know, we have to be cautious. I've done a few presentations about this at the Alliance conferences about, you know, we have to avoid pushing our agenda. Like if someone really wants to figure out how to live their lives, you know, with the same-sex attraction not moving, or, you know, whatever they choose to do with it, we have to center their agenda. Now, does that mean that therapists have to, you know, I've had people come to me, like lesbian couples, and they want me to help them with their sexual relationship. And I'm like, I don't know how to do that. I was not trained in that, and I'm not interested in doing that. It doesn't mean therapists, but I'm being honest. I'm setting the limits. I'm not pushing them toward anything. I'm just saying I can't do that. And that needs to be okay too. So I think I mentioned this before. Yeah, even without reaching these ideal goals. So this happens a lot for people entering therapy, wanting to develop opposite sex attractions, or wanting to diminish their same-sex attractions. They have a goal of perfection, right? And so that's part of the process, is realizing, wait a minute, none of us, you know, are there. And so helping them with supporting their client, their self-determination, their autonomy, actually ends up helping them to hang in there and increase their well-being, even if their goals aren't achieved, which is, you know, really important for this population, I think, because it can be a long haul. So there's this body of research that's been around for a long time. In fact, Carl Rogers, person-centered therapy guru, and from the probably late 40s, early 50s, he started doing research on outcome research on what is it that helps people get better in therapy. And apart from any other factor, we found that it's the therapeutic alliance. It's the relationship between the therapist and the client that makes the biggest difference. So whether you're a narrative therapist, a psychodynamic therapist, a cognitive behavioral therapist, it doesn't matter as much as actually creating a therapeutic alliance that is positive. And now they've started, these self-determination therapists, researchers have decided to look into this a little bit, and they found that one of the factors that is very high in achieving that positive therapeutic alliance is the the self-determination being supported by the therapist. And that is remarkable to me, that with all of this evidence and all of this background and research on what makes a positive, healthy experience, that it's being legislated against doing that. So limiting the client autonomy, as these legislative efforts are attempting to do, really truly does create a harmful therapeutic environment. When therapeutic goals, and this is straight from this body of research, when therapeutic goals are controlled by someone or something else, the client will experience increased anxiety, lowered self-esteem, decreased well-being, and a loss of internal locus of control. And this is what the other side is concerned about. I mean, legitimately, they care that some people are being forced into therapy. I worked with adolescents for years, and people are always like, oh, you can't force an adolescent to confront their same-sex attraction. I can't force an adolescent to do anything, especially I worked with adolescents with eating disorders. Oh my gosh, no, exactly. We don't force them to do anything. We can't. And we wouldn't want to, because we know that that wouldn't be helpful, or would be harmful. So really limiting limiting this autonomy is, no matter what, is not a good idea. I love this quote. It's one of my favorite quotes from a couple of the researchers. It's promoting patient choice through the clarification of values and goals, and facilitating growth through methods that emphasize ownership, personal responsibility, and awareness is thus an orientation that is not only allied with many of the traditional values of the therapeutic community, it is an empirically grounded approach to lasting change. Yet to be effective, it also requires therapists themselves being aware of their motives, it's huge, and protecting clients from controlling systems of incentives and pressures that can contaminate the process and climate of therapy. So this is why why I'm involved in this political stuff, because I'm trying to protect clients from controlling systems of incentives and pressures, because that's what's going on. These are very elaborate, well-funded systems that are pressuring clients. Again, I have to be aware of my own stuff and my own biases, and on a one-on-one basis with clients, I have to be careful not to push my stuff. But that's what's really happening right now is in the legislation. That's remarkable. Here are some, I always want to throw this in there too when I'm presenting about the background for this. There's a lot of research out there that has attempted, it hasn't been neutral. It's gone with an agenda to depict all safety as harmful. Again, motivations for this, another discussion. But here, some of these problems that have come out are that they're measuring only non-psychotherapeutic experiences. So now I'm a big fan of lots of support for people. In fact, I've told clients in the past, not about this issue necessarily, just in general. It's like, maybe, we need to get you a support system right now is more important for you than therapy right now at this point. So if you're going to be spending your time, helping yourself, let's get you a support system, support groups, whatever is available to them. So I'm a big fan of this stuff. And I think the research on this is huge, very important. But what's happening with, for instance, there's a study that came out by Blosnick et al. In 2020 that states that 81% of the participants in their study took part exclusively in religiously mediated interventions, not psychotherapy. So this is a study that was depicting safety as harmful, but they weren't doing safety. They were doing religious mediation of some sort. And so but they were represented in the counseling journals as safety. You notice that I don't use the other term that all the legislators use. It won't even come out of my mouth unless I'm have a psychotic break or something. I don't even use that term because it's a pejorative, and I just won't do it. But you know what I'm talking about. They're using these kinds of studies that are about something else. What happens a lot is they mix it up. And that's even true for some research that supports safety. It mixes up therapy with other, and so for instance, the recent Solins, Rosick, and Santero study, great study, but they had a mix of stuff. They didn't isolate psychotherapy, even though that was positive for supporting people's autonomy and self-determination. It was still kind of mixing them up. So those are some problems with the research. And this is another issue that I have never really figured out how to articulate this well, but what we're doing is not really, these legislators say that they're protecting people from treatment interventions, but these treatment interventions that they're talking about have been around for a long time and have been discredited a long time ago. There are already laws against doing some of these things, like electroconvulsive treatment for things that it doesn't help, rebirthing. These things have long been discredited. We don't need laws against them. There's already guidelines and regulations to protect people from that. So we know it's not about treatment interventions. These treatment interventions that they say happen are not happening in terms of therapy. It could be happening outside of the psychotherapy world, but we already have regulations for professionals. So what they're really doing is they're limiting the treatment goals. That's what they're doing, but they mix it all up and talk about it as if they're protecting people, and they're not. They're limiting their autonomy. Virtually all safety research is retrospective. Some of these studies where they're discounting safety as helpful, they're decade-old memories, like literally decades old, 40-year-old memories of these people talking about something that happened to them in therapy, again, using techniques that they used for all kinds of presenting problems. I talk about this a lot too. It was used for anxiety, same things. Rebirthing was used for depression. It was used, all of these techniques that we know are not good were used for all kinds of things, but we're not trying to outlaw people seeking help for depression, because once a long time ago, people used these interventions for depression. It's insane. I think I've said insane like 50 times now. So here's our study. These are the two big questions. And I've been focusing more on is safety safe, not so much on the sexual attraction fluidity piece of it. But these were the questions. The first one is about that. Can men autonomously influence their sexual attractions with the help of a professional therapist? And, Ali, as you were talking about doing this work, I loved that idea. It's these individuals that are going and seeking support in different ways that are doing the work. The therapists aren't doing the work. They're helping. They're coming alongside. The people doing the work are the clients, and getting in the way of them doing the work that is their responsibility for their lives is very harmful. So anyway, I just loved that kind of idea of this the people doing the work are the people who are wanting to make changes in their own lives. And then the second question is safety safe, and that's what we've been talking about. So I really like how this design came together. I mean, it was just how it was at the time, but there's been some research recently talking about doing this kind of design for outcome research, where it's in a real life setting rather than, recruiting people at a big university, which is how most of this kind of research comes out, especially empirical research. It's recruiting people at a big university and then doing very, very controlled treatment. And in this case, it was just, we just came in as observers in real life, collecting data from what was actually already happening in these places that are apparently doing all this harm, right? So we're going into these places that are apparently super harmful and just finding out like flies in the wall. And I said this all along, if I literally wanted to make sure that things were going well for people. I mean, if I had found that there was harm happening, I would have published that too. Well, it would have gotten published in 2 seconds. But, and another example of how this is being done are on studies now with substance abuse. They're starting to do this in just regular old clinics and gathering data on that and finding out what works. But the results is that what you find out from the study is you can generalize it a lot better. As I said, longitudinal, folks stayed in the study for 2 years. Repeated measures design, that means we were taking measures all along. And prospective is the opposite of retrospective. It's like in real time, we were gathering the data. And again, these were new clients so we didn't use any clients that were already there. So this is one of the reasons it took a while for us to get all the folks. If we had been able to use all of the clients that were existing, but we wanted to have someone who had never received this particular treatment. They may have been to counseling before. We didn't call them out, but they'd never been to the Breakthrough Clinic or the Thomas Aquinas Clinic where Joe Sr. was. They presented with an interest in exploring their sexual attraction fluidity. So all of these folks, that's what they got screened for from the beginning. These clinics see a lot of different people, not just that issue. And Ali already presented this. And I'm glad you put up that chart because I'm trying to remember how many people what percentage were Muslim, and you saw 9% of
I think like 7 of 75.
Yeah. So about 9% of them. So again, we can see they'll fall into probably this group that attended religious services a few times a week. The Roman Catholics and the Muslims are probably in that highly religious. 20, a quarter of the people are highly religious, and then we have about a quarter of the people who aren't. So that's kind of interesting that there are that many people that aren't highly religious who are interested in making this change and doing this work. I think that's really interesting that there are. That's what surprises me is like, wow, 25% of the people aren't highly religious. They're and then the 66% that are kind of a one time per week, those could be pretty religious people too, because Protestants tend to just go to church once a week, as opposed to the Muslims and the Catholics and the Jewish people. There weren't that many Jews in this group, but 83% identified as white. And again, you put this up there, so I'm going to go through this pretty quickly, but I do want to emphasize that 23% that said other, they're pretty similar to the other two, the wanted to marry a woman and religious reasons, but they checked more than one box. And some of them wrote stuff in, like the quest for value congruency was probably a direct quote from somebody. But it fits so well. I like to use that one because it fits so well with what we're talking about. So here's how we measured the well-being. This, let me get to my notes for that. The well-being was measured with an instrument, the OQ45.2, that's been used for decades. And the reason it was developed was for clinicians to be able to monitor in real time the psychological well-being and interpersonal and social, which I think that's another reason I really like this one, because we're looking at how people's relationships are going and how their work life, their college life, all of those things, how are those going? And so it looks at all of that. And one of the things we hear is that, oh, people who, you know, are wanting to go to therapy are having really hard time for this issue, but they're being rejected by their community, you know, their religious community or something. And we didn't see evidence of that as part of this process because they got healthier. So we did a baseline measure of that in the beginning of their well-being. And I'm going to go into a little bit more of that measure of well-being. The well-being, it's a really quick little test. They can do it. It's 45 questions. That's why they call it 45, but they're really easy to take. When they came in for their sessions, if they hadn't done their well-being measure, the therapist would just give them a chance. They could do it on their phone. And again, it was for the purpose of monitoring them, make sure that they're doing okay, checking in with them. And it's a very sensitive measure. We can tell if people are changing like within just a week or two. It's really a very good instrument. In fact, I introduced it at these clinics as my measurement, and they still use it, even though the study is long over, because they really like it that much. And then the sexual attraction fluidity was measured with the SAQ, we call it. This is what was used. Paul Santero developed this. We adapted it. It's not exactly like his original, but he used this for his dissertation. And it is what the Solons, Rossick, and Santero study also used this. And because that study is his dissertation, then with some additional information. So it measures the same sex, opposite sex, sexual thoughts, feelings, behaviors, and identity. And the behaviors, let me see if I can remember how it's described, is kissing and sex. And sex is defined as touching genitals or oral, anal, vaginal intercourse. So it's like pretty much anything you could think of. We wanted to make sure that we covered everything that people were doing, any kind of sexual behavior that was going on. And the intervention is reintegrative therapy. I have to say that I was really pleased that some of the reviewers were super interested in this piece. They got back, in their reviews, it's like, this sounds interesting. This sounds different. This sounds like something that we haven't heard of before, because they'd heard the reviewers of these journals have only ever heard about, rebirthing and electroconvulsive therapy and torture. And they're like, wait a minute, this sounds like really good. It was kind of funny. But it's described as a specific combination of evidence-based mainstream treatment interventions for trauma and addiction. So it really is mainstream. The reason it has its own label is because it's a specific combination and order, a protocol. And this was developed by both Joseph Nicolosi, senior and junior, and it continues to be developed. It's really kind of a living, breathing thing, but it has some of the same kinds of ideas. It's very much focused on addressing trauma in it. And Joseph Jr. has talked about the emphasis of client autonomy and self-determination being so huge, which makes a lot of sense for me. And looking at the raw data, and I might talk about this later, but from the well-being, these folks, their well-being improved very quickly. And I think the shame reduction, the emphasis on autonomy and self-determination, this empowerment that goes on in these clinics has a lot to do with what we saw. And here are the results. So we can see that the opposite sex attraction was increased statistically significantly for this group of men. Same-sex attraction experience decreased statistically significantly. And sexual attraction identity moved toward a heterosexual identity during this, during the treatment. One of the things that the other side, or the people who are anti-safety or anti-autonomy, are saying is like, oh, well, are they completely opposite sex? Who is, I mean, like, it's the most, we do not expect that for anything else. When people are presenting for help, we don't expect people for marriage counseling to have a perfect marriage or it didn't work. Is your marriage perfect? Well, then therapy didn't work. I mean, like, it's ridiculous. But anyway, what we found though is that there was so some people, obviously, when you're doing a group measure, and then we're looking at the whole group, some made more progress toward their goals than others did, but it is obviously fluid. And this is the well-being results. So even though we were measuring every single week, oh, by the way, we were measuring this every 6 months. This sexually, every 6 months we did this one. So we had a baseline before they ever started treatment, and then every 6 months after that. This one we did every week, but we only used the baseline and the post-test because that's what the instrument producers, publishers recommend, is for research purposes. The clinicians used it to do their work all along, but for the research purpose, we did the first and the last measurement, which was kind of nice. Oh, that's easy. And then we found a statistically significant difference. And so high is bad. Okay, the higher the score, the more distress the person is experiencing. The lower the score, the better the well-being. And so we found a statistically significant change with the score lowering. This is another important point. Every instrument eventually has, they develop, in addition to other standards, they develop this reliable change index. So it's a number that they say if someone, a change that is equal to or greater than that index, in this case 14 is the difference, it indicates that the change is a true change in the client's clinical condition. So we had an average change of 16.71, and they only needed 14 to demonstrate a reliable change. So that was good, a clinical, some of the reviewers were like, well, this is statistical information. What about the rubber meets the road stuff that clinicians are looking for? And this would be one of those. And also the post-test mean of 54.56 was well below the clinical cutoff. So when they ended, they were at 54.26, not 54.56. I noticed that typo. And so that's well below 63, which in the clinical cutoff, 63 or above indicates that that person's been in therapy there, or that person could use therapy. So that's quite a bit of a difference there. So statistical and clinical difference. I was curious about this too, because this was in a real life clinic, and as opposed to people coming in and having 6 sessions or 8 sessions, every single person having the same protocol. It was just natural. Whatever happens, some people get finished earlier than others. And so I was curious and wanted to be sure that there wasn't a relationship between the time and treatment and these other 3 factors, because that might indicate something that we would need to explore further. Fortunately, there were no correlations here. So the time and treatment wasn't impacted by how well they were at the beginning, how much distress they were experiencing at the beginning, or how much distress they were experiencing at the end. So the initial well-being, I was curious, like, oh, well, maybe because they were doing better, they got finished faster. Not really, because they just wanted to, they continued to explore. In other words, the well-being changed pretty quickly for most of these folks, but the process of developing the sexual attractions or diminishing the sexual attractions takes longer. Final well-being, I was concerned, well, maybe these people are just getting worse. And so I want to make sure that they didn't stay in treatment for a long time because they were just suffering. Nope, there was none of that. And the change in well-being didn't have any effect on that either. I thought that was interesting for me. So bottom line, reintegrative therapy intervention resulted in a remarkable improvement in well-being for men seeking sexual attraction fluidity. And sexual attractions are not immutable and can be autonomously influenced during safety. So, any questions?
Thank you so much. And wow, it must be amazing to, and I know you've done it a number of times in a number of different audiences, but to present 5 years of struggle and study, and as you mentioned, almost like a baby that's about to give birth, and like you mentioned, the struggles with getting it across more eyes so they see, getting it on the APA journal so a lot of people have access to it. Was there kind of reluctance to kind of accept the study in terms of everything seems like it's going well, everyone seems happy. So do you think did you experience any setback once you published and people have said these are ideal results which are coming out of this study?
I'm not sure about, I do know that when we were submitting it to the journals, that we get the reviewer comments, but the editors of the journals actually said, this is so different than the narrative that I am, in between the lines, I'm concerned about publishing this. There, because we've heard so many stories of publishers, editors of journals having to withdraw or having to apologize for having to publish something that's not popular. There was some, so I honestly think that was one of the big problems. In fact, none of them failed to mention that because this is so different than what the narrative is, in their own words, the study had to have been perfect. And one of the things, and I didn't talk about the limitations today, but because it wasn't randomized, we didn't have a control group because of the nature of the study. We were just flies on the wall. You don't create a control group. We didn't manipulate things at that level. So in a single group design, they said that it has to be better than that. Well, which doesn't make sense since everything that they've been using and everything they're publishing doesn't have that level of, that is trying to show the other results don't have that kind of rigor. But that's what they said, because it is so different than the narrative.
It's almost like the journal has to comply with the narrative and the narrative, which is crazy for science, right?
Right.
Yeah, yes. So amazing. I'm going to open it up to the floor. So let's see. So we have the Q&A option at the bottom if you're joining us by Zoom. And you can put your Q&A at the bottom, and you can also upvote as well. You can also, if you want to speak, you can raise your hand, but just be aware your name will show, and this is live, it's a live webinar. So if you want to stay anonymous, I recommend you use the Q&A function, and you can also use it anonymously. You can ask questions, obviously, in terms of the study and so on. One of the questions I wanted to ask was, with the statistical model that you used, And I remember you telling me that it was a really complex one in which it was, and it's, to be honest, it's even complex for us, the non-trained eye to look at it and say what's happening. Why was that chosen? What was behind that?
Yeah, it's a great question. It's so funny because in the very beginning when we were starting and we were designing the study, this was recommended. There's different names for it, and that's probably what's kind of confusing. But growth curve modeling was what I was first told, and it's a version of growth curve modeling. And basically, the statistician that I consulted with, which is very pro our side and really wanted us to have something, and another one confirmed, said, yeah, this is what you need to do with it, because it's going to show you the most, it's going to be the most accurate and give you the best, most accurate, unbiased results for a longitudinal repeated measures design. So, and by the time I got done, and I'm like, and I actually decided I don't want to do that. So when I did my proposal for the Institutional Review Board, I changed it to an ANOVA, which is the standard repeated measures. ANOVA is what we usually, analysis of variance is usually what is done for repeated measures longitudinal research. But it's not ideal, and because it biases it toward the people who stay in the study longer, and so you can actually have better results. You're more likely to bias it toward the better results. And I didn't want to do that. I didn't want to, because you have to drop out everybody who ends early. And so we wouldn't have been able to follow people for as long. We probably have only followed them for a year if we did that instead of 2 years, because we wouldn't have had enough data for all kinds of reasons. So what the model that we use actually is able to make up for the dropouts. And they're not dropouts, they're people who finish therapy early, right? So it's able to consider those in the data analysis. So anyway, when it came down to then, okay, it's time to start crunching the numbers. I wanted to do the ANOVA, and then I started talking to my stats people again. They're like, no, you need to do that. Then linear mixed modeling is what we ended up using. And because you can also do all kinds of other sophisticated, they can do some things that make sure that we're using the best model, the best analysis, and the best, basically what you're doing is making up for those lost people as if they were still there. And it's very sophisticated, and it's not you. So, but the ANOVA, all the stats people say the ANOVA, the repeated measures ANOVA is biased, and we shouldn't be using that anymore. Now that we have these other models, we should not be using it. And so I'm like, oh, okay. Well, and I'm glad they talked me into it. It was a lot more work, and there's a lot more little details to getting the data ready for that process. And I couldn't do it myself. And that's the other thing. I had to hire somebody to do it. I could do repeated measures ANOVAs, but I needed someone to help me through with that one. So I had to hire stats people.
Absolutely. I mean, the amount of data each person is filling that questionnaire, that assessment at every interval. So that's a lot of data, and obviously varying lengths of treatment. Yes, kind of a nightmare in terms of
right. You got it. Yeah, but it's good. It's good. I'm glad we did what we did. And I mean, the results, if we had dropped the, and I didn't even try it with the repeated measures ANOVA. I was thinking about, I'm going to try that out someday. And I'm like, no, I'm so over it. I'm not going to try it. But to see if it was different, that would have been fun to see. But yeah, it was a lot.
And I know you mentioned about now that you have the opportunity to speak to, kind of legislation and to say actually, and it is kind of ridiculous that we are talking about autonomy, right? And we're talking about it's not therapist led, it's what, and I mean, ironically, we have this in the UK that is, is client centered, like you're saying, even a narrative approach is what the narrative the client is bringing in. And yet still, even though there isn't evidence and the APA is saying there isn't any sufficient evidence one way or the other, that they still, because of pressure, political pressure, they are siding one way, and people who are brave enough, like yourself, who will stand up for that minority and will say that actually these are people who are seeking this, support. And I think that makes the study ever more personal, in that the people who've opted in probably have opted in to dispel or to show exactly what's going on in their lives effectively. It's quite a personal share for these people to put in. And in terms of the therapeutic intervention, because obviously it's 5 years, so you mentioned it was Thomas Aquinas with Joe Senior, and then Joe Junior with Breakthrough. Would you say, I don't know if you have the data, if it was online or if it was clinical, if it was, or if there's both, or if there's variations of that? Yeah.
I think there was some telehealth going on in it too. Yeah, definitely. Only because, and I can't remember how I know this, but I do remember I knew that there was some telehealth as well as face to face. It was mostly face to face.
And I think one of the other things is that the people who are accessing help is because there's almost no other help or no other thing which is available for them at that point. So I think that's quite important as well.
Yeah. See, I think I saw somebody raising their hand.
Oh yes, okay, yes, I've seen someone raise their hand. Thanks. So I'm going to allow Faris.
I raised my hand by accident.
Yes, thank you, Dr. Carolyn Pela, for the presentation. I have some questions about, first, I would like to thank you that your study is very unique regarding the follow-up, because I think it's a very important issue that all the clients could be followed up to, I think, more than 5 years also. So it would be very helpful if we continue this following up till maybe 10 years or 15 years to see how this study could be optimized. The second issue is you worked with people with eating disorders, and you used the narrative therapy, right?
Yes.
Yes. There is also another therapy which is also related to eating disorders called radically Open Dbt. And I think this could also be promising because it helps the clients to have radical acceptance and radical openness, which is also related to, I think, to issues like SSA.
Yeah. I have some supervisees that use that that form of DBT in addictions treatment, substance abuse specifically, and but do have some eating disordered folks who are comorbidity with eating disorders that are, and they like it. They yeah, it is a good one. in terms of following up. So this is one of the things in the design that I'm like, if I were to do it over again. One of the things we did with the consent for research is we limited the follow-up. And I don't know if I would do it differently, because I was concerned that people would like, I don't want you hunting me down the rest of my life, so I'm not going to be part of this. And that is one of the things that you do have to be concerned about with people making a commitment to, especially on this issue or anything sensitive like this, protecting them. You know, you come in and you do this and you're done. You do not have, you're not going to need to be part of this. It's not going to be something that's haunting you. You're just you're a participant for this period of time. Joseph Jr. and I were just talking last week about maybe doing something that does allow follow-up, and it would be really, it would be great to be able to do that and find out, you know, where are they 5 years from now, 10 years from now. That would be ideal.
Thank you.
Mm-hmm.
Thank you. Thank you, Boris. And as I say, you can use the Q&A option at the bottom, or you can raise your hand as well. And I think it's as we're discussing, it is a very personal thing to share, isn't it? And there is so much scrutiny on this that you would want. And I would say the people who do come forward with their stories are going against a narrative. I mean, let alone it's difficult to come out and say, you know, I have anxiety, I have depression. It's difficult to come out and say, you know, I'm going through a marriage, you know, breakdown. I'm going through difficult time. And for people to come out and say, oh, you know, and I was just saying this to someone else. I was saying it's easier to come out and say I'm gay, you know, than to come out and say, oh, I'm same-sex attracted and I'm getting help, you know.
That's so true. You know, if you come out and say I'm gay, they're like, oh, you're so brave. No, I tell you what's brave is trying to tell people that you're actually attempting to influence your own sexuality in this way.
Absolutely. So I think the participants are very, very brave that they have participated and they've allowed that intervention, a little bit of intervention, I would say, in a sense, that have then seen the results. And I like the fact that the result does document people who say, oh, actually, this wasn't what was for them, or it was their parents who are wanting it, you know, and that gives a real life scenario, because we do see those clients. And in strong support, you know, sometimes I ask people and they're like, what's your motivation? And they're like, oh, my parent wants to do it. And and people like that, they have been in the support groups and they don't stay long, because it goes back to just what you're saying. It's the self-determination, which if it isn't there, you know, if they're trying to please an external party, you can't do that, you know.
Right.
It's like I can't understand how someone could, because the work is very, very hard. It's a very difficult work. It's a very difficult path to take. So then if you were doing that solely to pleasing someone, you know, again, that's, I don't know if someone could be able to, could do that in that sense, because it does require, I mean, we're working with, especially in reintegrative therapy, you're directly working with trauma, you know. So it's heavy work in that respect.
Right. Exactly. Yeah, no, I've over the years, I've had parents bring in their adolescent daughter who is in a same-sex relationship, and you know, want me to do something about that. And you know, tell them, well, so I'm a family therapist. So what I want to do is work with the family. And some people will just, and at this later in my career, I'm like, that's all I'm going to do. I'm sorry. I'm not going to do this with an adolescent unless I can also have access to helping the family as a group, because sometimes that does the trick. I mean, it doesn't change necessarily her same-sex attraction development. Women are so fluid anyway. So what it does is it helps give the kid a chance to have autonomy and self-determination, which is what they're trying to do with these relationships with the girls sometimes. It's really interesting how it all, mixes together. But yeah, younger people, and especially the women that I've worked with, they really do have to own this. And I've certainly had so many young women come in who are like, had some sort of trauma with men and have developed some fear around, opposite sex. Even if they have opposite sex attractions, they reject that because they don't want that. So everyone has a different story. That's one of my big things, is like, there might be some similar elements, but how they got where they are and where they are on their path is unique. And that's, people need each other, and they need to hear those elements that are similar between each other, but to also recognize that you can't expect your path to go exactly like your friends who's going through the same thing. And that's important.
Absolutely. And it's like, it's like that with so many other issues that you can't just, it's almost labeling. It's like even SSA would be a label. Oh, I'm SSA, so I must have exactly the same experiences as another person who's struggling with their SSA. And like you mentioned, the narrative therapy approach focuses on the client's own narrative and how they see the world. And that's so important. And I think especially what you mentioned with female same-sex attraction, that it is sometimes not understood, or it's not, like you say, they have a higher degree of fluidity, and the reasons are normally more to do with emotional, kind of like emotional reasons rather than lust, or so it is different. It is even in strong support, when we have the women's circle, it's a very different approach, and it's a very different way of when we're dealing with. And I think I think the women are the minority within the minority. We talk a lot about male homosexuality, and it's almost like it isn't, it is difficult, or I don't know whether it's for the women to get help. And I personally had women calling up and saying, oh, we need help and we need support in this, but it's almost taboo, or it's almost like, well, it shouldn't really affect you, that kind of thing. And there's number of reasons where for that. So I'm so pleased that you are working with that population, which again is, even the study is a study of men, right? So it is underrepresented, and the if you like, the clinical pathways aren't that clear, and that's why having an extremely directive psychodynamic approach doesn't help if the client doesn't fit the bill, right? Yeah.
Right, because my experience of people, at least the books that are written on doing this work from a psychoanalytic psychodynamic approach, is first you have to kind of convince your client that this is why they experience what they experience. First, you have to get there before you can move. And, that's, so I have a different approach. I don't see that as, I'm not there to convince them. I'm there to be convinced. I need to know about their experience and how they make sense of it, what it means to them, not that they fit. And they could, we could figure out a way to put them into our box. And if that helps us, great. But they don't need to be convinced of our box. Just like it's the same thing as the gay affirmative folks. They have a box and they make sense of everybody's experience according to this box. And they don't know how to go on until you accept that you are gay. And it's the same kind of mindset. And so, yeah, that's one of the reasons I love the narrative work, is because we're allowed to go with what makes sense to our clients.
I mean, you've been doing this work for, it's over 20 years?
Yeah, let's say that. It's really a long time. I'm old.
Well, very experienced in this field. What across the years, and you have seen how the legislation and the media has become a lot more difficult. But what are some of your key moments, and and why are you doing what you're doing now? Because I know you're doing clinical supervision. You're still involved with it. What keeps you still fighting, still going? I heard you saying in the presentation, finally, I'm doing what I wanted to be doing. I'm going against these legislators, and because they have, when you put a legislation or APA or professional body, and it talks about something that they basically don't know about. They're talking about a population that they haven't really engaged with. That creates a vacuum for those people when that population can't then access the support and services that they need. Could be for sexuality, could be for something else that they take a politically correct view, which means that people who are outside of that then become a minority, and then the research and the science becomes a minority. But for yourself, you've stayed with that, that what most people wouldn't want in their career. What would you say, kind of makes you stick to the work, or what drives you? What makes you, I don't know, wake up on a Monday morning and say, no, I'm still fighting the fight?
Yeah. Well, it's not my whole life, I mean, it's like if it would compare everything that I do, I have a lot of ships that I sail and hop between. And, but I think probably this is very similar to what I'm passionate about in all my clinical work, is client autonomy. It is, it is supporting people's values. And I think, really the bottom line is God has put me in these places. That's how it feels like. Like, for example, Arizona Christian University, the president of this university started a Center for Arizona Policy many, many years ago. He's got rid of that before he came here. But one of his main areas of interest were the mutterings of this legislation all those years ago, and also marriage laws. So he is super supportive of everything I do. Like, I could be gone for a month and he'd be okay with it if it was on this issue. So an example of how God's just put me in places where I've gotten the opportunity and support to do this. But I also really do have this passion across the board clinically for supporting client autonomy, and rather than putting people in boxes who are suffering, rather than labeling them and pathologizing them and all of this stuff, is let's empower them, and let's get to where they are and help them walk through this walk. And and use the resources that they already have. I mean, but in particular, I remember when I first started working with women struggling with same-sex attractions. And I remember thinking at that time, I'm going to have to be careful how I document this, because even then it was not popular to do something other than gay affirmative. I mean, it really wasn't. And there were already, you know, people talking about someday there's going to be legislation. Someday you could lose your license for doing this. So I literally, from the very beginning, started documenting just my narrative kind of documentation, where it's people, you know, struggling with relationships or goals, value congruency and stuff like that. And so I think that's another way I've been protected, is just kind of having people tell me, like, you got to be careful. If you're doing that work, you got to be careful. And all along, writing my notes in such a way that there's no one that could ever say that I was doing anything like forcing people to have a different sexual attraction. I don't even use the word sexual orientation, because doesn't make sense to me.
Yeah, absolutely. I mean, it's the same stance we take, that, you know, the terms heterosexual, homosexual only occurred in the 19th century. Before that, we didn't really have these identities, as, you know, we had attractions, and unfortunately we are living in a world of identity politics, where you know, we pick a label and then we pick another label and make them fight against each other. So yes, yeah. How do people contact you, and how can people get to connect with you if they're watching this? And
my email is, I check my email all the time. I actually think that that's probably the preferable way. So it's my name, Carolyn.Pela at arizonachristian.edu, and Arizona Christian is one word. So that would be, that would be a great way. And
that's available on the study as well, which is on you've referenced it. So in case people are wondering which that one is, you can go on the study and you can get the email.
That's right. It's true.
From there as well.
Right.
Is there any message you want to kind of, or anything you wanted to deliver to the audience, or any closing remark you'd like to make?
Yeah, I think the only thing is just to reiterate that you're not alone, that there are people all over the world fighting for your autonomy, fighting for your self-determination, fighting alongside you if you're helping people with this. And also just the general idea is what you just talked about with the identity politics, refusing to be labeled and put in a box. And the more we can get outside of the boxes that people are creating for us in this area, the better off everybody's going to be. So when people try to, label you as ex-gay or crazy activist or, whatever, rejecting those boxes, I think, is a good idea for all of us. We are who God created us to be, and there's no box for that. He's still developing that. So I think that's a big part of this fight, is getting out of those boxes.
Absolutely. Well, no, I'm so glad that you've been able to publish the work, and you continue to help and support. And as you said, you feel that God has had that in your life, in this position, and what you're doing currently, and the support from the leadership of the university, which then allows for this oppressed population, as you said, which is being bullied by this community, by activism, and I think it's important to say it is activists. It's not all LGBT. It's these
Right.
LGBT activists who don't agree to disagree. They agree to ban you, agree to shut you down. And, you know, that is really extreme activism, which basically says, I'm not even going to tolerate what the other side is saying or doing.
Yeah.
And you know, we hope to with the alliance and, you know, with the journal of human sexuality, like I say, and for the audience which is listening to do have a look at that, see the resources which are out there, and you know, be knowledgeable. So when these things do come up, you know, we have experienced people like Dr. Caroline, you know, and the Alliance, which is always publishing research and so on. And in fact, you know, I spoke to Christopher Rozek, who and he was really interested in, say, Muslim community, what's Muslim community doing on this issue. And so if you are listening and if you are interested in any capacity to contribute, to, you know, add anything to this, to please contact us, and we'd be happy to participate. And you know, I think I would say be at the right side of history, you know, when they have this, and then have that actually these people had the courage to speak their truth in an atmosphere which is which bans us and doesn't really allow that autonomy which our democratic societies are meant to be built on, right? So
it is so bizarre that you take a little group of people and you create laws specifically for them to limit their ability to just live their lives according, like they're not going to hurt anybody by going to therapy, but somehow we have to have laws against that.
Yes, yeah.
So crazy.
Actually in UK there is the therapy isn't regulated at all, so there's no laws on therapy, so anybody can start a practice and call themselves counselor or psychotherapist because it isn't protected. Yet even with that, the first legislation in the history of United Kingdom which is talking about talking therapy is this bill. So you can see the gravity of the situation. And you know, I'm studying counseling at the moment, and one of the books that we read is by Peter Jenkins, and he's done a lot of work with counseling and psychotherapy. And I got to speak to him a couple of months ago, and he's on our side, and he's saying, "Oh my God, this is breaking client autonomy, and this isn't right." And I'm saying, wow. So, you know, people who have studied the law and counseling can easily see, especially with the gender identity piece, which is, you know, happening at the moment, where people are being forced into puberty blockers and transgender, that is just, you know, even medically doesn't have the science behind it. So yeah, and it was, you know, it was really good to see that actually if you do speak to the common therapist, or, you know, not the executives of these organizations, if you do speak to the common therapist, they say, oh yeah, we all know there's a bias, you know. So it isn't something, it's like an open, you know, everybody knows that there's an inherent bias in the report. And I think it just takes, I think this is the popular opinion, but people are afraid to speak out because they're afraid they're going to offend other people. And I think that's why it's so important, as you've mentioned, that we don't, even I have a bias. So we've had people who've come on and they've said, we want to be LGBT and Muslim. And I have said, like you said, that that's good. That's value congruency for you, but perhaps our approach isn't what you would like. But here are organizations which have that value congruency, and here you are. Instead, what's happening on the other side is saying, don't you dare go to this organization. They're unethical. And it's only a ideological difference, right? We have disagreements on many things in ideology, but to shut something down, and the first ever law in therapy in the United Kingdom to come to this, and that's why I'm so happy that the legislation is not calling it therapy, it's calling it practices, and it's recognized that, oh, this is not therapy, this has nothing to do with therapy. And therapy itself is so clinical. There's so many things that you'd love to say to the client, but you can't because you're in the protected, your professional boundary is if it's not coming through the client and you're thinking, oh, I just want to say this to you, but you can't because there's that professionalism. So it's so different from, like you said, religious or even support group. It's a completely different type of activity, and that's why they created a word which didn't exist. They created it, and now they're realizing, oh, it's a boogeyman, and it doesn't really exist. So that it's falling apart. But I'd like to thank you, Dr. Caroline, for taking the time today. I know you're busy and you've got many other responsibilities. So I really want to thank you that you have taken the time today to share with us. And I can clearly see how God has been instrumental in the work, in the beautiful work that you're doing with the university, I pray that you continue to do that, and if there is any type of support or help you do need from us, then we'd be very, very happy to support you.
Thank you, and thank you. This is a privilege. It really is. It does my heart good to be with people who care about this. So thank you.
Thank you. And thank you all for attending. And as I say, our next webinar is with, we'll be discussing the breakthrough clinic. So we have Michael Casparo who will be looking through emotional integration, SSA, and OCD. And hopefully that will be next month's webinar. And hopefully we see you soon. God bless.
Thank you.